My name is Dietmar R, and I will talk about the contribution of late neuropathological changes to neuron loss, granulovacuolar degeneration, and dementia in Alzheimer's disease. TDP-43 pathology is a frequent co-pathology found in Alzheimer's disease, and it has been discussed to belong to the spectrum of a limbic predominant age-associated TDP-43 encephalopathy, or short late. Neuron loss in Alzheimer's disease is associated with the accumulation of the necroptosis executor complex in granulovacular degeneration lesions. However, it is not yet clear whether TDP-43 pathology, or in other words, late neuropathological changes in Alzheimer's disease cases, have a separate effect on neuron loss and granulovacular degeneration / necrosome activation. Therefore, we wanted to test the hypothesis that TDP-43 pathology in Alzheimer's disease contributes to neuron loss and leads to necrosome accumulation in granulovacular degeneration in addition to tau. For this purpose, we analyzed 27 symptomatic AD cases, 79 non-demented cases with AD pathology, and 95 non-demented cases without fulfilling the NIA-AA definition for Alzheimer's disease pathology, including cases with primary age-related tauopathy, or in short, PART. We determined the neuronal density in the CA1 subfield. We performed immunohistochemistry for A-beta, tau, TDP-43, and phospho-MLKL. We determined the A-beta phase, the Bragg neuropathological stage, the serial score for neuric plaque pathology, the TDP pathology late NC stage, the GVD stage, and the percentage of GVD positive neurons in the CA1 region. We performed statistical analysis, including regression analysis. Our results confirm what we have shown before, that the entire necrosome complex can be seen in neurons affected by granulovacular degeneration, phospho-RIPK1, phospho-RIPK3, and phospho-MLKL. And phospho-MLKL co-localizes very well with the pattern that is seen for the classical GVD marker, casein kinase 1 delta. When we look for the number of neurons affected by granulovacular degeneration exhibiting the necrosome complex, we see that in AD cases, there's an increasing number in the CA1 region and in the layer 3 of the frontal cortex, and that this increase in the number of GVD affected neurons is accompanied by a decrease, by a loss of neurons in the same regions. When we look for the distribution of GVD pathology and TDP pathology, we see that it both starts somewhere in the medial temporal lobe and then expands to further brain regions, and finally the neocortex is involved as well. When we compare AD cases with and without TDP pathology, we see that the A-beta phase is similar. There's no difference in the A-beta phase, but the Bragg neuropathological stage and the GVD stage, they are both higher in AD cases with TDP pathology compared to AD cases without TDP pathology. More interestingly, we can also see that in AD cases with TDP pathology, we see significantly more neuron loss than in AD cases without TDP-43 pathology. Here, the neuronal density in the TDP positive AD cases is lower than in the AD negative TDP cases. In a linear regression model with Bragg neuropathological stage and TDP-43 pathology late NC stage as independent variables, we can see that both have an independent effect on CA1 neuronal density and GVD stage, as we can see here. Thus, we can conclude that GVD lesions contain the activated necrosome and are associated with neuron loss in Alzheimer's disease. Alzheimer's disease cases with TDP pathology show, in this context, higher GVD stages and more decreased neuronal density in the CA1 region than AD cases without TDP pathology. Tau and TDP43 pathology have independent effects on the CA1 neuronal density and the GVD stage. Thus, TDP43 pathology, or late NC, appears to accelerate necrosome activation and neuron death when present in Alzheimer's disease. And with this, I would like to thank you very much for your attention, and all the colleagues involved in this study. Thank you very much.